Then, of course, one of the things we need to look at is the pancreas also. And a very common condition that we get in the pancreas is pancreatitis. Probably some of you have heard about it. Hopefully, none of you have suffered from pancreatitis. So acute pancreatitis, of course, you have also chronic pancreatitis. So acute pancreatitis, most of the time will be gallstone or alcohol are the main risk factors. Remember the gallstones, before it enters the duodenum, the common bile duct joins with the pancreatic duct before it enters the duodenum. And so that gallstone can come actually and block there. And so in that case, it will block also the pancreatic duct, and it will lead to accumulation of, those enzymes within the pancreas and end up with pancreatitis. Of course, also alcohol use is one of the risk factors that is known to cause acute pancreatitis. Those are the main risk factors. Pancreatic enzyme cause tissue damage and necrosis. So premature activation of enzymes. So usually the enzymes that are produced by the pancreas, usually they are produced in inactive forms. Amylase, lipase, and others, they're usually produced in active form. They're usually activated once they enter the duodenum. But if you block it, and then they accumulate, they end up being activated prematurely. So they're activated within the substance of the pancreas itself. And then it will start digesting the pancreas tissues itself. So there is premature activation of an enzyme, and then they start destroying the tissues of the pancreas itself and even tissues surrounding it. And this one is likely to lead to high risk of multi-organ failure. So it's likely to cause failure of many organs. Severe cases result in massive chemical peritonitis, causing severe abdominal pain and shock. So most of the time, patient will come with severe abdominal pain and even can lead to shock. Because it causes peritonitis, which in this case is chemical peritonitis, because it is the enzymes that are released into the peritoneal cavity. They're usually supposed to be released in active forms into the duodenum, where they're activated now for the purposes of digestion. So there is extensive hemorrhagic necrosis of the pancreas. So the pancreas itself is destroyed by those enzymes, and then there's some bleeding into it. So hemorrhagic necrosis of the pancreas and surrounding tissues. So if you are to do surgery for somebody who has severe pancreatitis, you will just see hemorrhagic, the liver, the organs around it will be affected, including the greater omentum. So there is release of pancreatic enzyme lead to fat necrosis. So grossly, if you are to look with the naked eye, there are numerous chalky white spots in the peripancreatic and omental fat. That means the omentum, the greater omentum, will be affected. So if you are to look histologically, there are foci of necrotic adipose tissue surrounded by a ring of foamy histiocytes. So histiocytes basically are macrophages, which contain phagocytosed lipids within their cytoplasm. So they phagocytosed lipids, and we have what we call foamy histiocytes. I think we also mentioned about this when we were talking about I think it was in Pathology 1, when we talked about some of the conditions that affect the main blood vessels. So these are some of the causes. Gallstones, most of it, 60%, alcohol, 30%. Hyperlipidemia is high lipid level within the blood, high cholesterol levels. Of course, trauma, as I told you, any organ can be affected by trauma. And if there is direct damage, it can lead to acute pancreatitis. Also, drugs can affect it. Some poisons, some venoms, some infections, and some are idiopathic. That is basically we can't be able to find the cause. Somebody has acute pancreatitis, but we cannot tell the cause. Of course, we have chronic pancreatitis that can follow repeated episodes of acute pancreatitis. So if acute pancreatitis are repeated episodes of it, then it's likely to lead to chronic pancreatitis. And most of these chronic pancreatitis tend to be alcohol related and tend to be irreversible. So at this point, you cannot be able to reverse the damage. And usually there will be a lot of scarring and no loss of gland tissue. So the cells of the pancreas are usually destroyed, and then there's a lot of scarring. And it's likely one of the things the patient will come with, one of the pain they will come with will be back pain. Remember, the pancreas is retroperitoneal organ, just like we talked last time. So it will be something at the back. So you're likely to feel pain at the back. And then, of course, there is risk of diabetes because remember, if the cells of the pancreas are destroyed, it will include all the cells, including probably the isolates of Langerhans that produce insulin. And so if you destroy them, then you are likely to have deficiency in insulin. So basically, you end up with diabetes. So key factors, you have fibrosis, low vascular tissue, there's atrophy of those tissues, the ductal changes, the ducts, that is the pancreatic ducts, there are changes, they may be narrowed, they may be blocked. There's chronic inflammation, and then there is isolate cell, that is the isolates of Langerhans, the cells that produce insulin, pseudo-hypertrophy. So they appear to be hyperplasia, but really that's pseudo, because there is loss of acina cells. So the other cells that produce the enzyme are lost. So you end up seeing like there is a lot of isolate cell. Really, it is pseudo-hyperplasia because of the loss of the other cells. Key features, you have perineural inflammation and neuronal sheath hypertrophy. So around the nerves, yeah. And this one is the one that will explain the chronic pain. So somebody will tend to have chronic pain because you can see the nerve, the perineural and neuronal sheath hypertrophy and inflammation. Fatty infiltration, you have steatosis, acinoductal metaplasia. So you know what metaplasia is? So that epithelium will be changing. There will be metaplasia. And the presence of dystrophic calcification. So likely to be some calcification within the pancreas itself in chronic pancreatitis. And some of the complications, of course, that we mentioned, diabetes, pancreatic insufficiency, that is basically the pancreas is not able to produce the enzymes that are useful for digestion. And so you end up with steatorrhea, is basically fatty stool. There's a lot of fat within the stool because they're not being digested. Malabsorption problem with absorption, yeah, because of lack of those enzymes. You're likely also to form what we call pancreatic pseudocysts. So you look at a cyst, but it's a pseudocyst. It's not because of, it doesn't have a capsule or anything like that. The pancreatic calcification, periductal calculi, so you can have stones forming in the ducts, in those ducts of the calculi. You can have stones, calculi. Then ascites, you can develop ascites. There's a picture there, just basically a diagram showing some of the things, complication, pancreatic pseudocyst, calcification within the pancreas, ducts, calculi that are stones within the pancreatic ducts. You can have ascites, that is accumulation of fluid within the peritoneal cavity, fat malabsorption because you don't have, the enzymes are not coming for digestion. So you end up with fat malabsorption. Then pancreatic adenocarcinoma, that is basically the cancer of the pancreas, usually tend to affect the head of pancreas. Yeah, initially it's insidious in growth, that is basically, it tends to be slow growing, and somebody is likely just to present with obstructive jaundice because especially if it is the pancreas, the head of pancreas, likely to block that common bile duct, and you end up with obstructive jaundice. So usually presents late with painless obstructive jaundice. So somebody doesn't have any pain, but they have jaundice, deep jaundice, they have obstructive jaundice. Usually they tend to have poor prognosis and median survival approximately 6 months. So after diagnosis, most of the time the people survive for just about 6 months. So it has a very poor prognosis. And if you are to look at macroscopically, that is with the naked eye, you likely to see the tumor being hard and white because mostly there is this stromal reaction. That means there's a lot of stroma formation, there's a lot of fibrosis. Yes. And if you are to look under the microscope, you're likely to so they have a ductal pattern with marked, that is pancreatic adenocarcinoma, variation in size and shape of neoplastic pleomorphism. They usually arise from the pancreatic ductal epithelium, so it occurs from the epithelium of the ducts. And it tends to be more common in males than females. So after the age of 50, the incidence increases progressively at the age of 50 years. And it tends to be infiltrative growth pattern that basically tends to infiltrate into the pancreatic tissue and even surrounding tissue. And these are some of the factors that are implicated in etiology of cause. Things like smoking, diet, so depending on some food that are thought to cause it, obesity, chemical carcinogens, diabetes mellitus is thought to be, could be one of the risk factors also. If you have chronic pancreatitis, it's likely to lead to this adenocarcinoma. Also, infection by Helicobacter pylori. Yes, so basically, commoner in males and in female incidence progressively increase after the age of 50 years. Infiltrative pattern, as I've already said, so it tend to get into the tissue, the pancreas, and so on. And these are some of the factors that were implicated in causation etiology: smoking, diet and obesity, chemical carcinogen, diabetes mellitus, chronic pancreatitis, H. pylori or Helicobacter pylori infection. Remember the Helicobacter pylori that we talked about when we talk of gastric cancers, duodenal ulcers, and so on. And then some genetic factors are thought to be some of the causes.